Thanks, Eric. So as Eric mentioned, my name is Michelle Ramírez. I am intensivist at NYU, now called Hassenfield Children's Hospital. And about 80% of my time I spend in the cardiac ICU, and about 20% of my time these days is at the pediatric ICU. So I still do a little bit of time there. And today we're going to be discussing point of care ultrasound documentation and billing. And this is a little bit of a dry topic. I know it's not as exciting as, you know, when you're getting your views, learning to use ultrasound to put lines in. But it's actually a pretty important topic because it's how we can generate revenue. And we know that if you don't generate revenue, it's hard for you to ask for and justify needs to your hospital and your healthcare system. So let's see. Okay, so I had made a couple of pre-questions that because before we were asking you guys for a pre and post question, but obviously we'll just go for it because we don't have the system for the answers for you guys to input the answers. So this is a 7-year-old male who has URI symptoms for a week. Morning, woke up with lethargy and increased work of breathing. The vital signs were significant for tachycardia, tachypnea, and a blood pressure of 74/42 and sats of 87 in room air. On physical exam, you heard scattered crackles and decreased breath sounds on the right. Distal perfusion shows cool extremities with a cap refill about 2 seconds. Your differential diagnosis includes pneumonia, sepsis with shock, and myocarditis. You roll over your ultrasound machine to help you include or exclude these diagnoses. And in order to receive reimbursement for this POCUS, you must A, make sure that you bill for both professional and technical services. B, document with a note of the study in the chart, which only requires specifying the indication, type of exam, and findings. C, uploading and storing your study images for 2 years. Or D, ensuring that you document it in the patient chart as either a separate procedure note or by placing POCUS findings as part of the daily patient progress note. And I'm not going to answer this now, but as we go through the lecture, you guys will be able to figure this out, and then we'll come back and go over it again. So I have nothing to disclose. And in terms of our objectives for this talk, we're going to emphasize the importance of ultrasound use and proper billing in pediatric critical care medicine. We're going to identify the requirements of documentation to achieve reimbursement for POCUS. Recognize the minimal number of saved images and storage time required to bill for POCUS. And you guys will get familiarized with the relevant and commonly used ICD, CPT, and modifier codes for POCUS. So a little bit on the background. I think we're all familiar with how critical care ultrasonography continues to grow, and most programs, for most fellowship programs, it's become a standard. And through the last decade, I think like the adults have definitely had an upper hand here, but we're finally like starting to catch up as well. The use of ultrasound is invaluable for both diagnostic and procedural interventions. We all use it for line placements, paracentesis, thoracocentesis. So it's become an invaluable tool at the bedside. Most pediatric critical care CPT codes, when we're billing under 5 years of age, are bundled. So we lose a lot of opportunities to get reimbursement. However, at this point, POCUS is billed separately. So this is something that really can allow us to get extra billing from the patients. Now, everything I'm going to say has a caveat, and that is that a lot of the things that I'm saying here, so I'm in New York, so a lot of these things are going to be general, but New York has its own regulations and every state has its own regulations. Your hospital might have its own institutional regulations. And remember that your ICD and CPT codes are periodically updated. So make sure that you double check all these codes and all these things to make sure that you're compliant with your institution. So WHO. Since 2010, the Centers of Medicare and Medicaid, so CMS, and CMS is usually the one that dictates the rules, and then private insurances usually follow CMS. So everything I'm saying here, even though it's from CMS, it's also going to apply to private insurances. So they decided to follow the policy that the AMA started, stating that any physician with appropriate training in POCUS could bill and expect payment for services. And what do we have to do in order to be able to provide the service? And is there anything specifically that we have to record? So we're going to be talking about these things as we go along this talk, but we're going to talk about the minimal image requirement and the minimal documentation requirements that must be met. So how many images should be stored? That's going to be a little bit variable, but we'll talk about that. Where should they be stored? And then what elements do you have to put in your note? And is there a specific note that you need to be using for these? So in terms of images and where to store them, I think that as with any protected patient information, we know that anything that we store that has to do with a patient should be in a compliant storage system. So you shouldn't be using your personal computer to store any information. Depending on your hospital system, you might have different requirements. Now, CMS requirement is that you should allow for at least 5 years of storage. So they should be able to go back 5 years and retrieve images from a particular patient. In New York, that number is 7. So your state might have different regulations. So make sure that you check on what your regulations are. But the minimal any place is 5 years. And then what systems do you use? This is going to vary by hospital. Some hospitals are using like their radiology PAC systems. In some hospitals, it's become a little bit of a turf war, whether the PAC system could be used or not when it comes to POCUS. So they've used different cloud-based storage systems or some different drives to be able to store the images. Now, for billing purposes, you can either have a static image or you could have a video like a loop image. And we know that videos will usually provide more information, but depending on what you're looking at, the frozen image might be sufficient. And I'm going to talk to you about a little bit about how many images should be stored. This is per our institution. So our institution has its own requirements. So look again what your institution requires for your minimal images. So this is from our NYU policy in terms of like the POCUS policy that we have at our hospital. So for cardiac POCUS, you need to have 3 out of 4 views, and those views could be either the subxiphoid, the parasternal long, the parasternal short, or the apical 4. So if you have at least 3 different clips from these 3 of those 4 areas, you're good. Now, if you're looking, for example, for a DVT, they require 2 clips, and they want you to look at the groin area. They want you to start at the common femoral saphenous junction and compress every centimeter until you're past the bifurcation. If you're doing like go to the popliteal fossa, and then you're going to compress the vein, then compress a second time at the trifurcation. So that's our regulations. And again, check with your institution to see what would be your minimal requirement of storage. So what about documentation? So depending on your institution, some places have templates already that are incorporated for POCUS, or some places will just put it into their daily progress note. Now, there are certain things that must be included for billing purposes. Obviously, you have to have the name of the patient and the medical record number, like you have to have the identifying information of who that study belongs to, but then you also need to have who performed the study, why you performed the study, the type of exam that you're doing. Then you're going to document your findings, you're going to interpret those findings, and then remember the image storage, which has been mandatory since 2005. So these are 2 samples of the different documentations that you can have. In these notes, there's no patient identifiers, but that should be in the EMR. So the first one is a template for just a procedure note. And you can see that it includes your operator. They have an indication. They have like a little procedure checkbox that makes it just really easy to go through that. Then they put all the findings. So in this patient, they performed an echo, a chest ultrasound. They did abdominal, looking at the kidneys, and they looked for DVT, and then they put the interpretation for each one. So that's very straightforward and very simple. Then on the next one, you have your critical care daily progress note. You can see that you have that little section here where you put your findings of the ultrasound. And then it's more information is justified when you're looking at like your cardiac or shock information. And that way you can combine and put all the elements together. I think it's a little bit easier when you have a procedure note template rather than having to put in your progress note and making sure that all those elements are in there, but it's really gonna be institutional dependent. And what else do you need to put? Well, you have to make sure if you don't have an ICD diagnosis, then you are not going to be able to get reimbursed. So you have to make sure that you indicate why you're doing that, and you use an ICD code for that. So for chest ultrasound, here's a list of like different things that you can input into your ICD code to justify your ultrasound. So if the patient has dyspnea, if they're hypoxic, if they have an effusion, if you're concerned about pneumonia, all those things can prompt you to get a chest ultrasound. Your patient in shock would justify an echo POCUS at the bedside, or if you're concerned about cardiac tamponade, if you're getting abdominal ultrasound because you're evaluating for ascites, or you are looking at kidneys for AKI. And then of course your vascular ultrasounds, if you have clinical signs that there might be a DVT, then you put that into your ICD code. So for example, if you have a patient that had a neurosurgical procedure, and then all of a sudden those patients start having increased work of breathing and they look labored, you want to perform a chest ultrasound because you want to make sure that there's, for whatever reason, either fluid accumulating or they didn't have a pneumo. Then you could put, like, for your chest ultrasound justification, you could put dyspnea in there. If you happen to find an effusion and you're going to do something about that, then you can add pleural effusion and you can add your CPT codes into that for the procedure. And we'll look at that in 1 second. But before we talk about that, there are two types of studies that you can do. Progress. There are two types of studies that you can do. You can do a limited or you can do a complete study. So most studies that as intensivists we're going to perform at the bedside for purposes of POCUS are going to be limited. We're not going to be doing like a full study. If you are doing a full study, so if you are also working in the cardiac ICU and you're a cardiologist by training and you want to perform a full echo, then you have to make sure that all major structures within the area are there. So for example, if you're just looking for a effusion and you just look at the pericardial region and you just look for a pericardial effusion, but you don't look at the valves, you don't do a function, you don't look at the aorta, and you don't talk about all those areas, you don't do all your Doppler gradients, you cannot bill for a full study. If you perform, so let's say if you're doing an abdominal study just to look for if there's ascites, and you find ascites, and then when you're looking, you think that there maybe is something in the gallbladder, and you decide that you want a full abdominal study for that patient, and you send that patient to radiology. You cannot bill for a limited study and a full study in the same day. Obviously, at that point, don't bill for your POCUS because most insurances will try to take whatever is less, and obviously a limited study will bill less than a complete study. So at that point, let radiology be the one that bills for the full study. So I think we're all familiar with CPTs, or the current procedural terminology. It is basically a language created by the American Medical Association, so we could have a uniform way of discussing coding for medical services and procedures. There are 3 different categories. There's those that describe a particular procedure or service. There are those that are supplemental codes for performance measurement, and then there's those that are for data collection and payment for services that are not included in the category 1. For purposes of POCUS, we're going to be talking about mostly CPT codes that apply to that category 1. There's 2 different components, and for our purposes as intensivists, we're going to be always talking about the professional component. When you talk about technical components, you're talking about cost of equipment and supplies, what it takes to maintain the ultrasound machine. If there's a technician that is involved in completing the examination, that's also included in the technical component. And this is something that actually the hospital bills for. If you happen to have a private practice, so if you're an outpatient provider and you have a private practice and you have an ultrasound machine, you can also bill for the technical component. But since most, if not all of us are employed by a hospital, the hospital is taking care of the billing. So what we really do is the professional component, and that you can add to your CPT codes as a modifier. And that's basically what we do by interpreting our studies. So any medical service that the physician provides, that interpretation component, that's going to be what we bill for. And that's going to include diagnostic and therapeutic imaging, if you're using it for any pathology, or when you interpret the test. If, let's say, your patient is in shock and you get like a quick function check, and then you start inotropes and you want to see how your patient is responding to your milrinone or your epi, and you decide that you want to repeat that exam, you can repeat that exam and put the modifier 76 to that CPT code. And if your partner who comes in after you did it during the day, and then it's the evening, and then they're doing an exam, then you could put the modifier 77. However, in some insurance companies, your entire group might be considered same physician. So you'll have to look at that minutia before separating if it's a 76 versus a 77 modifier. But you can definitely get more reimbursement for reassessing the patient. Okay, so these are just a few of the CPT codes that you might be using when you're doing your POCUS at the bedside. For the cardiac ultrasound, you're going to have your limited or focused exams. So if you're doing your transthoracic echo, that's going to be your 93307. And if you're doing a follow-up study that is limited, you're going to do 93308. If you're doing like your full study and you want to do a complete echocardiogram with M mode, that's going to be a separate code, and that's your 93306. If you need to perform a procedure, like if you are doing ultrasound guided pericardiocentesis, then that's a separate code as well, and that's 76930. And now let's say that you're doing a chest ultrasound and you're doing a diagnostic portion. So the patient that had respiratory distress and you want to make sure they have an effusion. So you do a chest ultrasound and you do find an effusion. So then you decide that you're going to insert a chest tube. So you can use those two separate codes to add to your CPT codes. And if you happen to do that again to check, like we said before, then you would do like your 76604 and add either the modifier 76 or 77, depending on the situation, if it was yourself or a different physician. What else? So vascular access, I think this is really common for us to use this. I think most of us are now placing lines under ultrasound guidance. And depending if you're using it to, some of us use it to just find the vessel, but you don't follow through for your line placement. And some of us use it to find the vessel and actually look at the needle and make sure the wire is through and all those things. So depending on that, you can use different codes. So if you're using it to locate the vessel and make sure if they're patent, then you can use 93971. And when you're using it to guide your placement, that's a separate CPT code, and that's 76937. And remember, you have to be able to save those images that you're using for line placement and for identification of vessels to be able to bill for those. So how do we put it all together? So now you have a 7-year-old male, URI symptoms, lethargic and increased work of breathing. The vital signs are significant for tachycardia, tachypnea, and blood pressure of 74/42 with sats of 87. You hear scattered crackles, you have decreased breath sounds, your perfusion shows cool extremities, your cap refill is about 2 seconds. You again are thinking of a pneumonia, sepsis, shock, and myocarditis. So you bring your ultrasound machine to exclude these diagnoses. And in order to maximize reimbursement for this POCUS, what are you going to do? Are you going to perform a cardiac ultrasound to check function and build 93306, which would be a complete echocardiogram with M mode? Are you going to add the technical component modifier to your CPT code when you're performing the study? Are you going to perform the chest ultrasound and bill 76604? And if you see a right-sided effusion, do your thoracocentesis and then bill for a 32557 CPT code. Or are you going to save your images to a password protected personal computer? Now, hopefully this is really an easy question for you guys after everything that we talked about. I'll tell you that the answer is C. So hopefully everybody saw that. The other ones were pretty nonsensical after what we talked about. And yeah, you're not going to add a technical component because what we said, as an intensivist in the hospital, you're not going to be doing that. It's not a full study because you're only looking for a function check. And then you're never going to save your images into your personal computer because it is patient protected information. Okay, so some references for you guys and any questions?